Good afternoon. My name is Jim Bensley, and I'm the Interim Director of the NMC International Affairs Forum. Today, we have a special opportunity for you to hear about a topic that certainly needs no introduction, the COVID-19 global pandemic. While the majority of us in northwestern Michigan have been vaccinated, that's unfortunately not the case in many parts of the world, including India. As you can certainly see from almost any news source, the situation in India is quite dire. That's why, as part of our IAF Global HOTSPOT series, we wanted to offer a connection to the front line regarding what's being done to serve so many of those in need. Today, we're excited to welcome Ms. Edith Elliot, co-founder and co-CEO of Noora Health, an organization unleashing the power of patients and their family members by training them with the skills to tremendously improve clinical outcomes, provide care, and save lives. Edith has a background in global health research, program implementation, design thinking, and a passion for meeting users where they are. Prior to Noora Health, she worked first at the Aspen Institute and then at Population Services International, focusing on contractable disease prevention efforts. She has her BA in International Relations from Tufts University, her MA in International Policy and Global Health from Stanford University. Edith is an Ashoka Fellow, a Rainier Arnhold Fellow with the Malago Foundation, a Draper Richards Kaplan Foundation Fellow, and a 2015 Echoing Green Fellow. In 2016, Noora Health was recognized by Fast Company as one of the 50 most innovative companies in the world, and number 2 in India. Noora's program has reached over 1 million caregivers, and their pandemic response has reached more than 14.8 million people across India and Bangladesh, equipping them with life-saving information and training on COVID-19. Welcome, Edith.
Thank you so much. It's really a pleasure to be here. It's nice to see your face, Jim, after talking a few times.
Well, it's great to see you too. And let me say how grateful we are to have you here, as I know your work at this particular point must certainly be all-consuming.
Yeah, yes. It's been a very chaotic few weeks for sure.
Well, before we get into exactly what Nora is doing and what the current conditions are like over in India, let me first ask you about Nora, okay? The organization obviously started prior to COVID, but why and how?
Absolutely. Yeah. So our story goes back to 2012. I was a graduate student at Stanford, getting my degree, as you mentioned, in international policy. And I had the pleasure of taking a course at the design school, which is a part of the university that doesn't offer degrees, but where students from various different backgrounds come together to learn about design thinking. And the course that I took at the design school was called Design for Extreme Affordability. And you're introduced to an organization or a partner abroad, typically, who is experiencing a problem, and you use design thinking to help solve that problem. And in our case, the partner is a chain of hospitals in India. And I had worked in the global health space, but had not spent any time in India or done any work in India. And the folks who ended up being my co-founders, my colleagues who were in this class and who were also assigned to this project with me, had similarly not spent much time in India and did not have very much experience. And so we were coming into this with very much a beginner's mindset and a blank slate, if you will. And what we found will come of no surprise. You have incredibly crowded, dense hospitals. We saw that be the case whether you were in the public, government-run health system or the private healthcare system. You have doctors and nurses who simply don't have the time to provide the aftercare instructions to patients that would then set them up for success coming out of a hospitalization. You're lucky in India if you get 2.5 minutes on average with a doctor or nurse during your entire hospital stay. And in Bangladesh, we also work in Bangladesh, it's even shorter, 48 seconds on average. You're handed a bag of pills, a piece of paper with some discharge instructions that you may or may not be able to read and understand, and you're told good luck, and you go off hundreds of kilometers away. And then on the other side, you have family members who travel to the hospital, live at the hospital throughout the duration of their loved one's stay, but outside of visiting hours are left to wait, pray. They're not engaged in the healthcare system formally, and we found, here you have this incredibly capable, willing, incredibly resourceful and compassionate resource in the family member. What would happen if you engage them in the system, if you trained them with tangible skills, not just patient information, but actual skills, so that they could be hands-on with the patient, an extra set of eyes, ears, hands to advocate for the patient during the hospital stay, and then of course better prepared to care for the patient when they return home. And as I mentioned, we started this work back in 2012. We had no intention of starting an organization. It was just a graduate school, it was a class that we took, and we thought, well, let's create something for this chain of hospitals and then go back to our lives. And things snowballed from there. And we found there was so much death and suffering that was happening after people returned home that could be easily prevented if people just knew what to do. So wound infections, you have readmissions and complications that were easily preventable. And by engaging families in this way, triggering the behavior change around, say, hand washing or wound management, medication adherence, things that are actually very difficult behaviors to change, capturing people while they're in the hospital and engaging them in the right way was a really brilliant way of then, turned out to be a helpful way of getting those readmissions to come down, complications to come down. So that's where we started. And now, as you mentioned, we're working in over 160 hospitals in India and work very closely with the government. And my co-founders and I, our other life just kind of took a back seat as things snowballed.
So let me ask you this, for the audience, some of you don't know, but Edith is actually based here she personally is based here in Traverse City, yet she
Yes.
runs an organization that's thousands of miles away. As you were putting this all together, you obviously chose this area. Did you find any complications in setting up the whole the technological infrastructure to make this all happen?
Well, and Traverse City, to be honest, happened it was a bit of it wasn't planned, so to speak. I didn't say, oh, okay, I'm going to live in Traverse, and instead this work will be, I'll be here, but the 170 other people on my team will be in India. That was not the plan. So my husband and I lived in India for almost 3.5 years. We were there. So from when we first started working on Nora, I was back and forth to India, and we had team members who, we hired and joined who were based in India. Then I eventually moved because I was spending 50% of my time there, and it just became really difficult. So we moved to India. We're living there. And then I had actually come back to the US just for the holidays. My parents live here. They're my neighbors, just right through the woods on the other side of this house. And we've been coming up to Traverse City every summer of my life. We have, like many folks who end up living here full time. We had a summer base here, but never pictured it being my home base. And so I had come back to the US for the holidays, found out that I was pregnant, and I had some complications. I couldn't travel, essentially. I was told you have to stay put. And my husband and I had, we found ourselves, we had actually purchased a cabin that didn't have heat, was extremely rustic only because it was right next door to my parents, and found ourselves in the position where we couldn't, it was sort of we can't have rent in India, we can't have a mortgage plus rent, it just became this, it's the summer, so let's just be based in Traverse and see what that's like. And then slowly it just became very clear that this is where we wanted to live if we were going to be in the US. So my daughter was born in November of 2019. And the plan last year was to spend about half of the time in India and half of the time here. But alas, as all of us experienced our plans last year, none of us, they did not go as
dramatically changed
yes,
many plans.
Yes. And we transformed the cabin into a home that has heat, which is very important with a baby in the winter. Lived with my parents in their very small home for a while. But I love Traverse City, and there are 4 of us based in the US. Otherwise, the rest of the team is in South Asia, between India and Bangladesh.
Yeah, well, great.
Grateful for
We're
Zoom.
glad you're here. So,
Thanks.
so let me give you a little bit of background. A few years ago, I took a group of students to India, and we went to Varanasi, and of course, the Ganges
Hmm.
runs right through there.
Yep.
And as we went up to the shore, I asked the students. I said, "Why don't you dip your toe into the river?" And they're like, "Well, that river's pretty dirty. I don't know if I want to do that." I mentioned to them that they had learned in class that is a holy river. That's
Hmm.
that's the place that many people try and get to, certainly before they die.
Yep.
So I said, let's just dip your toe in there, because you're going to regret it if you don't do that when you get back. So using that as sort of an analogy, or a metaphor here, let's dip our toe into the river of COVID and find out what the conditions are like in India. So
Yeah.
how do you see, what's your impression of the situation right now in India with COVID?
It's horrific. It's beyond description. It is, sometimes with news and media sensationalizing things, you think, oh, is it as bad, or what is the real story behind this? But I will say it is as bad, if not worse, than the headlines we were seeing. Now, of course, India has dropped out of the headlines a bit, even though cases are still astronomical, and there's a huge amount of underreporting that's happening. And we feel confident saying that because of what we've experienced on our team this time. So with the first wave of COVID, it was devastating, of course, for the country, but India fared relatively well from, or appeared to, in terms of, death count and whatnot. Um, but this time, it's not just numbers for our team. It's not numbers, it's names. Every single person on our team has either fallen sick, someone in their home is extremely sick, or someone in their immediate family. On top of that, every single person on the team has had not just one, but multiple deaths in their family and in their close community. And what we are seeing with the communities that we serve with our beneficiaries, so folks who live in tier 2, tier 3 in very cities and very rural areas, is even more catastrophic than what our team has experienced. And what we're hearing from, other NGOs and other partners in the space is the same, that every single person on their team, and my husband's work is in India, and his, same. So clearly there's a huge amount of underreporting that's happening. And we're, while it has dropped out of the headlines a bit, there's no end in sight. We don't see, there's not light at the end of the tunnel, unfortunately. And India's, Modi had promised one of the largest vaccine campaigns in the world, but last I looked, I think it's less than 5% of the country is fully vaccinated. So you're talking about like, the tiniest drop in a very large bucket. And so we're, our COVID response, I'm happy to get into our COVID response, but in terms of the reality and the situation on the ground, everything that you're reading is true. And unfortunately, because most of the headlines you're seeing are coming out of Delhi and Mumbai and, urban centers, because that is, you have dense populations, there's been so much spread, but a lot of why it's getting attention is because it's hitting middle class and upper, there's no, all of a sudden you have this hugely, a huge part of the population that has been directly impacted in a way that perhaps during the first phase of the pandemic, it was not. And the inability to get a bed, the inability to get oxygen is something that everyone, it doesn't matter how much money you have. I was talking to a friend whose aunt is extremely, one of the wealthiest people in the country, getting 15 phone calls a minute. She can't get a bed for someone. If she can't get a bed, if she can't find an oxygen cylinder for someone, then imagine living on a few dollars a day, what the situation is for you. And so, oh, you might hear my little one, apologies, in the background. She's
That's fine.
nap time, so there might be some crying with grandma. But it's just horrific. It's absolutely horrific.
So let me ask you, we talked about less than 5%, I think it's around 2 or 3% of the
Yeah.
population being vaccinated in India. What do you think went wrong after,
Mhm.
initially it looked pretty good for
Yeah.
India?
I think it was a combination of things. One, after the first wave, after people fared relatively well and the country fared well, you saw this huge sort of a relax happen. And that meant people stopped wearing masks, people were not social distancing, which already is incredibly difficult in India. People were let their guard down. And in a country that is so densely populated, that means if something becomes viral in this way, it's wildfire. Um, the other thing that happened was the government was in no way, they should have seen and should have known when the other variants started popping up in other parts of the world, should have realized, okay, could be catastrophic here in India, gotten the oxygen ready, gotten the infrastructure, the physical infrastructure ready and prepared in case the worst happened. And instead, what happened was you saw huge political rallies. You saw things like Kumbh Mela being able to happen and continue. Modi himself was hosting political rallies in it's unthinkable, right? That already there were signs of the virus taking hold in certain parts of the country, and this was allowed to happen. So, in the first wave, there was this immediate shutdown. I can't remember the exact timing. It feels like a lifetime ago, but I think it was 6 p.m. They announced that at midnight the country would, or opposite, at midnight announced, and then 6 a.m. It was, you only had a few hours to prepare, but it did help stop the spread, right? So it was terrible execution, but it did help stop. And this time around, almost the opposite happened, where it's just been let continue. Essentially, it's only more recently that you have lockdowns. So there's been a massive government infrastructure failure, and beyond that, we've helped mobilize oxygen concentrators. And I was sharing this story. We had 200 oxygen concentrators that we procured and then mobilized to rural areas in one of our partner states. And getting those oxygen concentrators into India, then getting them from Delhi into the rural areas, from a logistical perspective, was so complex and so difficult, because for a number of factors. One, foreign aid moving into India. Some of you have seen, I imagine, some of the reports about the government's extraordinary restrictions on foreign aid coming into the country. So from step one, there's so much money being raised, there's so much attention, so much awareness, billions of dollars, but that money cannot pour into the country, because what has happened as of last year, there are new regulations that stipulate an NGO, an organization, has to have something called FCRA. They cannot now subgrant to a smaller organization that doesn't have, or that does have, FCRA. And because of that, that means you have a UNICEF or one of these huge entities that usually would take money and then trickle it down to more grassroots organizations. They can't do that anymore. So they don't have the boots on the ground to mobilize resources. So in the face of a pandemic, when the international community is stepping up, and when so many people are trying to step up, what we're seeing is money can come in, resources can come in, but they're just stuck because the government has such they've really strangled the ability for aid to be dispersed. So it's just a huge breakdown on so many levels.
Wow. And obviously Nora has witnessed that on a day-to-day basis. You and your team have to kind of throw your hands up sometimes, I imagine, and just say, what, right? What's going to happen?
Yeah. Or just say, you know what, we're powering forward, and we move forward, and you say sorry later, or you deal with the consequences, because this is, people are dying. People are dying every day. I just saw someone asked a question about the sort of privatization, or private versus public. Yes, the majority of healthcare in India is privatized. It is delivered through the private health system. This can explain a lot of the disparities. And certainly the government infrastructure the public health system caters to the very poor and the rural poor, and quality is of massive concern. And so, yes, if a private hospital in Delhi doesn't have oxygen, then again, you can imagine the situation in some of these public facilities. And even though the healthcare system is very largely private and out of pocket, some of what I was mentioning before still puts a strangle on the private healthcare system's ability to execute in time of extreme distress.
So, and I just want to remind the audience, please, if you have questions for Edith, put them in the chat and we'll get to those in a few minutes. One question that Bob Giles posted, and is similar to a question I have, today in today's New York Times, they talked about the black market, right?
Yeah.
About India falling prey to what's called predatory profiteers.
Yeah.
And everything from oxygen to fake vaccines to treatment drugs.
Yeah.
And they're out there and they're selling. Have you seen this happening? And if so, how do you work with families so they're not fleeced and desperate?
Well, and unfortunately, it's not just sort of the black market where you're seeing some of this happen. There's also been a huge overuse of steroid treatments. So there's now this horrible fungal infection that people are getting. There's, you have in a system where you can go to a pharmacy and pick up medication without having to have, a formal prescription at times. People are trying to self-treat, self-medicate. So what we do and what we're doing has been very much focused on always upskilling and training family members. And right now during COVID, one of our core programs, or part of our core response, is we receive phone numbers from the government of COVID positive individuals who are in home quarantine. So people who have not progressed to the point where they're in the hospital. And with those phone numbers, we then are able to call and train their family members and the patient if they're well enough, but really focused on the family members, and help them understand how to support the COVID positive patient through the illness and recognize when and if it's time to go to a hospital, understand, do they have a pulse oximeter? If not, here are some of the things to look out for, teaching now about proning and whatever we can do to help keep the patient comfortable and help the family understand if and when it's time to seek care. And part of that absolutely has become dispelling myths, trying to dispel misinformation that people are getting, trying to help people understand, this wonder drug or this type of treatment may actually not act in the best interest of the patient. And so just absorbing a lot of that misinformation, and then doing our best to train the family and the advocate for the patient on what to do or what not to do. And most importantly, how to keep other members of the family healthy, which can be very difficult to do if you live in a one-room home and you don't have a separate bedroom, bathroom, whatever it might be, to isolate the patient. So helping people understand what they can do within those restrictions.
Yeah, so Edith, talk a little bit about that, right? With the dense population, certainly in Uttar Pradesh, up in the northern part, that's got to be obviously more difficult. Can you tell us a story about a family? Do you have one where you've had your people on the ground working with them, and they've accepted help from Nora, and where they're moving, hopefully in a good direction?
Yeah, we get stories pouring in every day, but one that sticks out, there was a gentleman who himself was a healthcare professional, found out he was COVID positive, and that other members of his household were COVID positive, and was so grateful. He was a nurse, and he said, for all intents and purposes, I know all of this. But in the moment when you are so sick, and when you are, he could not be of support to his family, having that lifeline, having someone who cares, having a number where there will be someone on the other end to answer questions was such a gift and was so important, and helped his family move through their COVID experience. And that stood out to me because you realize, and you often hear doctors say, you kind of forget when you get sick, or like as a doctor, you see your child get sick and you're a pediatrician and suddenly you're caught off, you don't know, and you're calling your friends who are pediatricians asking for advice. And it humanized it in a sense for me, that here is someone who he's out in a rural area. He doesn't, they don't have much in the way of, money and means, but that they felt supported in that way was so such a gift, as he put it, to him and his family. And they were able to keep the other members of the household. In India, it's communal living, multiple generations live together, and they were able to keep some of the more high-risk individuals who lived in their household safe. And luckily, they got through the illness and had a couple of scary days, but otherwise have come out on the other side now. And the government health system doesn't typically provide that type of support. And one thing at Nora that we do, it's not, hi, this is Noora Health calling to train you. It's government of fill in the blank state that we partner with. This is very much seen as a government initiative. And it's that for us is important, because we're creating sustainability within the system. We're trying to raise up the system versus promote and raise up our work. I just saw Richard asked the government's motives for all of the restrictions. You could go down a rabbit hole if you if you want to look into this, but in particular, the foreign aid restrictions. There were many years ago, there were several organizations that were seen as doing basically things that, so the BJP government is Modi's government, and things that were seen as anti-BJP, and they're a very nationalistic entity, and a lot of human rights work and whatnot that they were not in agreement with. And so they shut that down. And this is a way for the government, this FCRA, Foreign Contributions Act, is a way for the government to very closely monitor all foreign aid coming in. So the Ford Foundation, for example, several huge nonprofits were kicked out of the country. They've now since been able to come back, but with very strict restrictions. One of the newer restrictions that was put in that's made operating extraordinarily difficult is you have to have a bank account if you're bringing foreign money into the country. You have to have a bank account with the Central Bank of India in Delhi. All foreign money has to come through that bank account if you're a nonprofit. And so, talk about one way to monitor is having all of the money go through a single central government bank. So they're scared of what will happen if they're not in control.
So what can the United States do? Is there any way we can intervene? Can we encourage others? I mean, how do you see us playing at the sidelines of this in India?
At a national level, I think continuing to encourage and push aid in the right way and in the right direction. So certainly, vaccine support, all of that is helpful. I think at an individual level, what each of us can do is be very thoughtful and careful with your giving. Right now, oxygen, monetary support is hugely helpful, tremendously helpful, if given to and if targeted at the right organizations. And so be sure to do your due diligence. There are a handful of grassroots, on the ground, folks who have boots on the ground who are desperate for money, or organizations like ours where money might be less of the concern, but we are sitting here as an open door saying, hey, if you've been able to get oxygen concentrators into the country, or if you know an organization that has, but they're having trouble mobilizing them, that's where you can step in and say, oh my goodness, I know an organization that can help you mobilize them, not to the urban centers, but actually get them out to the districts, to the areas, to the far-reaching parts of the country that really need help right now. So I think being a very thoughtful, in terms of being proactive, being a very thoughtful donor or advocate for organizations who are doing good work. And if there's anyone who's looking for names of organizations, I'm happy to be that bridge and to provide some connections. And I think from a national, at the national level, there's a lot of diplomacy. I think if one thing could come out of this, it would be the Indian government's, one good thing would be for the Indian government to realize that foreign aid and foreign participation is perhaps needed and required at the moment and for moments long after.
Well, speaking of long after, I mean, hopefully at some point, COVID will run its course, the vaccinations will happen. I mean, that's what we all hope and pray, for India. But, and once that happens, what will be the role of Nora at that point in time? Obviously, what you've been doing prior to COVID, but do you see any support sort of being pushed forward from your organization that time?
Yeah, one thing it's important to remember during a pandemic, people continue having babies, people still have heart attacks, people still have these routine daily incidences that happen, health events, health crises. And so we will continue to be there in those moments of crisis as Nora. And we don't unfortunately think that COVID is going anywhere anytime soon. So for us, in the same way that our maternal and newborn care program is core to our work, COVID, we anticipate being a core part of our offering for at least the next 12 months, if not longer. We're doing quite a bit of work with UNICEF on vaccine distribution, on dispelling myths around vaccines. That's going to be a huge undertaking and something that is going to take quite a long time, and because the population is just so massive, and there is a lot of myth and misconception that has taken root. And so from a communication perspective, there's going to be a lot of work coming out of the pandemic around vaccines, especially if we find out that you have to get the vaccine once a year, or this is something that that all of that is still to be determined. So 12 months from now, I anticipate that the role that the family plays in someone's health outside of the formal health system is only going to be more prominent. And our hope is that we can elevate that role for millions, tens of millions of families in the country. I just saw Carla asking, Jim, I can share some names now, or I could email them to you and you can share them with the group. You tell me.
Yeah, why don't you just share a couple names right now while
Sure.
we've got everyone online here.
There's a group called SWATH, and let me just quickly try to find the website, but they're really fantastic. There's Pratham. They do education for the most part, but they have an unbelievable, it's one of the largest NGOs in India, but they have an unbelievable network that they're now using for health, essentially for COVID response. We work very closely with them. Noora Health, of course, and we again have our boots on the ground. And let me just try to find Pratham and Swath's websites for you. And Pratham has both the US, if you're looking for a charitable deduction, they have both the US arm, but they do have FCRA, so they're able to, you can donate in the US and then it's sent to India easily. And similarly, Noora Health. Swath, I don't think that they have a 501c3, so you don't get a tax write-off with that, but that's up to the donor.
Edith, you're doing such great work over there. I love the whole, as I say, mission that you have to serve others and educate others. That's a vital role in any community, especially in developing communities or communities that are, very poor. Are there other organizations that have seen what Nora is doing and have said, hey, that's a great idea. Can we help? Can we work in partnership with Nora to expand the reach over different communities in India?
That is our dream. Our hope is that others see what we do, and that this concept of family member engagement, it becomes viral, and we put ourselves out of business. In an ideal world, this would become a WHO protocol, and you would have every hospital everywhere in the world. This is part of the pre-discharge checklist, is your family member has to be trained and engaged before the patient is discharged and leaves the hospital. We have had several organizations come to us. We were actually doing some work with the Henry Ford Health System down in Detroit before the pandemic. That's been put on hold for the moment, but essentially working as thought partners to try to translate some of what we do for their health system. And inquiries like that have absolutely popped up. And part of our COVID response has been training other NGOs, training other organizations to then be armed with COVID information and tools that we've built to then go and train, go in and engage with their beneficiaries. And in doing that, we've seen this idea that, sort of similar to the community health worker model, that health information doesn't have to live in the ivory tower, that there are things you and I can do very easily if given the right information, the right skills training on how to do them. And I think just that reframing and realization that it's not all as complicated. Let's leave nurses and doctors to do the really complex things, and there are things that you and I can do. And so there's, I think that our hope is that coming out of this, that realization that, oh yes, family, so much of health does happen at home. There is we cannot exclusively rely on our health systems. We have to rely on one another, on ourselves and on one another in many ways. And so we'll see if that's one of the, more positive things coming out
great.
of this. I'm not good at double tasking, so I'm just getting this other website up for you. Yes.
Janet Ward has a question, and
yes.
I think it's kind of similar to what you're doing now, but she says, if we have family or friends in India who may benefit from Nora's services, how can we refer them?
Absolutely. Here, I'll put my email into the chat. So please just feel free to put them in touch with me. Yes, if you know anyone who is COVID positive or who has friends, loved ones who are, please give them my email address, put them in touch. And we're happy to do our in-home training, and we're also doing some resource mobilization, as I shared. You can also go to our website, which is just norahealth.org. I suppose I should have had all of this pulled up. Apologies. And you can see our COVID response and get in touch with us that way as well. Here we go. And there are materials on the website for home isolation. We've created a list of protocols and tools for training that you can access for free on the website in multiple different languages.
Great. Richard has a question. This is a great one. Is there an element of tribalism in determining who receives aid?
Absolutely. There's, in India, we often say our job is to reach the most high need populations and most vulnerable. In India, there's so much, there are so many diverse religions. There's so much diversity that very often you see bias coming into play in ways. It's not just gender based, or it's not, or socioeconomic based. There's a huge amount of religious biases as well, and tribal. There's sort of this perception that you're not seeing in the news, for example, very much about what's happening in some of the more remote tribal areas. And that's because they don't have a voice. It's hard to get those stories amplified and into the news. and it certainly, I think in the months to come, as some of that does get more traction and becomes more available, those stories become more available, it's going to be incredibly tragic to see in retrospect some of what had happened in the more remote areas before the aid was able to catch up and trickle out. Oh, I think you're on mute, Jim.
Thank
there
you.
we go.
All right. So we have time for just one or two more questions for Edith. If anyone has one, please feel free to type that in the chat right now.
Oh, oops, I think I've been just messaging the panelists with these links and not messaging everyone. So I don't know if
We
all can see them.
Edith,
You
don't
can
worry
share
about
them?
that.
Okay, great.
We'll take care of that from our side.
Excellent.
Yes. Yeah. Let me ask you, again, you talked a little bit about where you envision Nora, but I want you to look 5 years out, okay? Is this something that is just India, Bangladesh, that sort of Central Asia specific, or could you see this blossoming into Thailand and into Argentina, those kind of things?
Yeah, our 5-year plan does include expanding into between 2 and 3 additional countries, and we plan to stay in for the next 2 countries, stay in South India and then South Asia and then Southeast Asia. But then as the 5th country, do plan to venture outside of the region. And look, having been a caregiver, having been a patient myself, I know the anxiety and confusion and those emotions that one feels when going through a health crisis, and seeing those same emotions in caregivers around the world. That's part of what inspired us and inspires us every day to do this work. And we feel this is a universal option for healthcare delivery. This is not something that's isolated to India or Bangladesh or one part of the world, or one group of people within one part of the world. We feel very strongly that this is a more compassionate, it's a higher quality, it leads to higher quality care. I didn't share some of our research findings show, we've been able to reduce post-surgical complications by over 70%. We recently had a body of research come out in the maternal and newborn care space that shows we are reducing mortality by 18% for newborns. That's saving 9 lives out of every 1,000 live births. So there's, in addition to some of the more, behavior changes that we're able to drive and whatnot, we're also seeing very real clinical outcomes as well. And it's extraordinarily low cost because you're not having to add a device or a widget or something into an already very complex system. You're just harnessing and tapping into an incredibly committed, devoted, existing resource and a resource that's already doing this, right? They're already providing care. This is just providing support to that resource and streamlining things. And so our hope is that, like I said earlier, we hope there are other governments, NGOs, organizations that pick this up and try to replicate. Having competitors, quote unquote, would be a happy outcome for us. So right, if anyone knows anyone who's trying to do something similar, you see some of these initiatives here and there, for parents of children who are terminally ill, or for in small niches, you do have family training happening, but not something that's more generalized. And we hope to spark that movement. We'll see.
Great. And we've got one final question. And I think this is a really good one. What support is the U.S. that was it.
How much of an impediment?
I think Steve had one. Yeah.
How much of an impediment is the caste system? I mean, I think that gets back to it gets back to the question previously about, tribalism and very much so, very, very much so. There's, again, a reason that that a lot of the headlines that we saw, and a reason that a lot of the attention that was paid to India a few weeks ago was in these urban environments. And I think that what I've experienced is, while the caste system is supposed to be a thing of the past in India, it's very much a thing of the present. And it determines, for many, it determines everything from the moment you're born until the moment you die. And that's part of why Nora started, was we saw huge inequities, even within a government health system, within a government hospital. Someone's ability to get the attention of the doctor, get the attention of the nurse, advocate for the patient, was very often determined by the perceived background of the person that was receiving care. So unfortunately, very much an impediment.
Yeah, it does. As you say, I've seen that with the work that I've done there too with students.
Yeah.
It's always there. It's always there.
Yeah.
Do you have time for one more question, Edith? Because if you do, I'd love to ask this one from Steve Horn. And he says, what support is the U.S. government providing, or is this solely a private effort?
The U.S. government recently committed a fair number of vaccines to vaccine doses. I don't remember the exact amount. Let's see, I should know that. And there's been some aid that has poured in, but it hasn't been, to be honest, I think part of why it hasn't been as significant as it could be is because of this nationalistic attitude that the government in India has.
Okay, great. Well, our time is unfortunately up. I think this has been very interesting, listening to someone who really is working with us on a daily basis, right? The tragedy that's happening in India, and that we can all hope and work towards, finding a solution to this. And that's not easy, right? COVID's not an easy thing to wrangle with, but
no.
Organizations like Nora are doing a terrific job. Thank you for providing the address. We'll get that out to everyone, so you have places to go to find out more if you'd like to help with their efforts over in India.
Thank you so much. Thank you. And there was a really interesting article about, just Steve, to your question about this in the Brookings. I was just trying to find it quickly for you. I think this is the one, Jim, but this group might find it interesting. So I know not everyone is getting these links, but it talks a little bit about the missteps that the U.S. government made when it's come to this crisis in India, and how the foreign policy team could have been more proactive and done things a little bit differently.
Hindsight,
a lot of
vaccine.
Exactly. A lot of, most of this is what is it being called? Vaccine diplomacy and vaccine diplomacy missteps. So.
Oh, great.
What you take
well, Edith, thank you again for taking the time today and being with, informing of us on what is happening over there and what Nora is doing and what we can do to help that see a better light.
My pleasure. Please, anyone, it's just edith@norahealth.org. Feel free to reach out to me, and I would be delighted to connect you to folks. And please, if you know anyone in India who is suffering or who runs an organization who could use some of our content material and resources, we would be delighted to connect with them. So thank you so much.
Fantastic. And
have a good one.
And all of you out there, please join us on Thursday for our discussion with Ling Wei, and where we're going to be looking at China. Big player in the world, obviously.
Yes.
And so we'll be looking at that. We're excited about that opportunity as well. So take care.
Stay healthy,
have a wonderful
everyone.
day.
Thank
you.